Welcome. I'm trying to, so I've got some different glasses, so I'm trying to look at different screens at different distances, and if I look silly, I apologise, but okay, well, welcome. We've got a public question that was submitted, but it wasn't about the content of the board or the things we're discussing. So my proposal was that we respond to that, but we do it as though an ordinary inquiry into the trust. I think that was what seemed sensible at the time. So if you're content with that, we'll do that. Okay. Yeah. Thanks so much. Julie, any apologies?
No, no apologies.
Okay. Declarations of any other business?
No.
Declarations of interest in the register or the agenda items? Minutes of the meeting on the 14th of July. Any corrections, please?
No. No.
Okay. Action log and matters arising. I think looking through it, I think everything's either in train or not yet due, although there were one or two things which are sort of at the beginning were grey, the status is grey, and I think it might be useful just to review that sometime, perhaps not now, but there's whether one or two of those we need to delete because they've been overtaken by events. But I can't see anything that's outstanding unless anyone can see anything or wants to raise anything.
No.
Okay.
Martin, sorry, Martin, just very briefly, there's a couple of actions there that were completed at the last FIP meeting. So when we get to my report on the last FIP meeting, I'll cover off on those.
Thanks so much indeed. That's helpful. Okay, let's move on then to the quality section, item 6, patient story. And David, I think I hand over to you. Is that right?
Yeah, I'm just going to hand straight over to Joe, actually, who's got a presentation to give to us. So Joe's one of the NHS graduate trainees. It's an award-winning scheme, and we're very lucky that we got Joe and a few of the other graduates working with us at the moment. So Joe's just going to give us a presentation on a sexual health service and just talk to us about the experience of that service through the COVID period. Obviously, each service has experienced it differently, but I think it just gives a bit of an insight into how services have responded during this period.
That's great. Okay, over to you, Joe. Welcome.
Morning, everyone, and thanks for having me. I'll just share my screen for this presentation I've prepared. So I'll start off just giving a brief sort of summary into the service. I've been working there since April, as David said, as part of the NHS graduate management scheme as sort of a project manager. So the sexual health is an integrated service, which means that we provide care for, your standard sort of things that you'd expect at a sexual health service. So STIs, reproductive healthcare, contraception, things like that, and also HIV, which is commissioned separately by NHS England, whereas the sexual health contract held with the local authorities. The service covers all of East Berkshire, and we're mainly based at Upton Hospital with 2 sort of satellite clinics, one at Skimpard Hill and Bracknell and one at St Mark's in Maidenhead. The service has been delivered by the Garden Clinic for around 30 years, considered widely to be sort of the leading integrated sexual health service. It's quite unusual to have a service like ours based in the community. A lot of HIV services are in acute settings, and it's sort of seen as quite leading in terms of the integration of the reproductive health care, the STI and the HIV service together. So we had a new tender released in summer 2019. Well, that's when the contract was agreed from. So under the terms of the new contract, we're going to be providing we do provide a walk-in service for sexual health patients, dedicated young persons clinics with sort of vulnerable and young patients as sort of a key cohort for the service, a new digital way of working, which I'll talk about slightly more, and home delivered STI and STD kits, which you can just order off the website. So this slide sort of shows what the old patient pathway was like and what we're aiming to get the patient pathway like under the new sort of digitized service offer. So under the old model, patients arrived to the walk-in clinics at the times that we had them available, which often meant that they were waiting for a significant amount of time. There wasn't really a triage system. It was just a case of, the clinicians that are available will see whichever patients come in. They checked in by speaking to the receptionists, which some people felt was sort of cause for concern with regard to confidentiality, because obviously it's quite sensitive subjects that are being discussed. And then patients would have to just wait in the clinic until the clinicians became available, with a significant number being turned away if the demand was high. They'd be seen by a doctor, as I said, that was available. And if it just so happened that they ended up seeing, you know, a lower banding of clinician, they might have to come back for another appointment, which obviously just not really a great system. So under the new model, we're trying to sort of move towards online booking as much as we can, under which the patients could get sort of triaged via an online algorithm and then book a slot which we make available that suits their schedule, so they just can come straight in. It gets rid of that sort of waiting times element. We've got a self-check-in device which is installed at reception, sort of similar to what you have at GP surgeries, where you just walk in, indicate your date of birth and stuff like that, and then it will just say, okay, great, go through to the waiting area, which gets rid of that issue of confidentiality. Patients then arrive at the time they've booked for, which gets rid of that waiting time obstacle. And due to the online, the algorithm that's built into the website, which we also mirrored for patients that do still attend for walk-in, patients are seen by an appropriately skilled clinician based on, you know, the symptoms that they identify themselves as having. So at the start of the COVID period, we sort of focused on a number of areas to reduce the risk. The first one was our triage system. So first of all, we halted all walk-in attendances at our clinics. We asked all patients to contact the clinic via phones, which would allow our receptionists to manage them via a triage sheet, like a sort of crib sheet that we developed in consultation with the doctors and the senior clinicians. This allowed us to make sure that the most complex cases would be referred immediately to a clinician for a telephone consultation, called into clinic if it was something really urgent, or referred over to 111 or A&E if needed. We also paused our online booking system to make sure that symptomatic triage, so what I mean by that is that people with symptoms of COVID weren't able to sort of book themselves in without having speaking to someone first. And we extended all of our HIV prescriptions to make sure that our most vulnerable sort of immunocompromised HIV patients didn't have to attend the clinic unless it was absolutely necessary. For patients who did attend the clinic, we introduced a number of safety measures quite quickly. So plastic shields around reception, allocated seating for patients at social distanced areas. We had a load of signage and a one-way system put up to reduce face-to-face interaction. Masks and sanitizer was made available at every entrance and exit and was made mandatory for everyone who was entering the building, be that staff, patients, delivery men, whoever really. We followed all of the guidance on PPE and tried to limit people actually entering the building who needed to. So for example, if someone was just coming to pick up prescription or some medication, they'd be asked to wait outside and have stuff sort of put out rather than entering the clinic. For our vulnerable cohort, we sort of gave them what you might consider a bypass for the triage system. So anyone who was young or vulnerable would immediately get a telephone consultation with a clinician, regardless of their other symptoms. So they'd be sort of fast-tracked on to make sure that we didn't miss them. We undertook welfare calls for our high-risk patients, so people that we'd sort of had at the clinic before were called by our health advisors to make sure that they were aware that we would still see them if there was anything urgent and that they were safe. And that work was actually recognised by Public Health England, and they asked us to write a best practice case study on it, which was great, and it's going to be up in the National Archives. We also worked to reaffirm a lot of the relationships with our health system partners, so the third sector, the local authorities, other people who sort of deal with vulnerable patients, to make sure that those networks were dealing with people as appropriate. And we made sure that we carried on our safeguarding meetings and sort of reaffirmed a lot of our policies to make sure everyone was doing the same thing throughout the COVID period. For our staff, we instructed everyone to work from home whenever it was possible. So anyone who didn't need to be in the building obviously wouldn't be asked to attend. We made sure all of our meetings that were held virtually and recorded, as I'm sure a lot of people did, and Teams really took off and communication via that became really widespread, which I think was particularly great for people who were, shielding or not coming into the clinic for any reason, to help them still feel part of the team. We made face masks mandatory on premises and sort of tried to cut down interaction in shared areas, so things like staff rooms as much as we possibly could, and encourage social distancing in clinic, not just for all the patients, but for staff as well. a bit of reflection on what we sort of think worked well and what we possibly could have done slightly better. I think the triage system was very effective. It was something that we sort of developed quite quickly in consultation with all the senior leads for the service, and we got it in place very quickly for the next week. And I think generally it worked really well and made sure that we were only able to see the people who we absolutely needed to. The safety measures I discussed that we put in clinic very quickly, I think worked well. So for example, the plastic shields, I think we had installed by the end of the next week after the lockdown was announced. So I think that was a really good sort of symbol for the staff and patients that we were taking things very seriously and that we were, you know, introducing as many measures as we possibly could. For our clinic, I think because it wasn't something that was an area that was particularly overwhelmed with COVID, if anything, we saw a lot less patients had a bit of time. It was great to have some management lead, particularly for me being new to the service, to look at a lot of our policies and have a bit of introspection and think, you know, why do we do this? How can we do it better? So the safeguarding is a great example of that, where we developed new sort of flow charts and policies and audits to make sure that everyone was adhering to the same standards of practice. We updated our website and all the external facing materials, so things like the answer phone and social media very quickly to make sure that patients were aware of our updated service offering, and it worked very well. You know, no patients actually turned up for walk-in after that. And the communication with staff was clear and effective, and Teams really played into that well. Staff were able to access all the IT equipment they needed, so it let us allow people to work from home quite quickly and easily, and I thought that was really great. And our engagement with young and vulnerable patients, particularly the vulnerable cohort, and just doing the sort of allowing them straight through the triage process, I think that worked really well. In terms of what we could potentially have done better, I think in the very initial phases of the pandemic, we were very focused on making sure that step one, we need to make sure that we'd have a lot fewer patients attending the clinic, which meant that possibly we took slightly longer, maybe a few more weeks before we introduced the measures around staff working from home and things like that. I think we got sort of carried away with our priority needs to be making sure that our patients cut down, and in some ways that meant that the staffing took slightly more of a backseat in the very initial phases. We put quite a lot of energy into making virtual consultation technology available, so the one consultation, and unfortunately in our service we possibly had slightly limited staff buy-in. They feel that some of the patients just weren't keen on, couldn't see the benefits of doing a video consultation over a phone consultation, which is a shame considering, you know, the successes that have been had with this technology in other parts of the NHS and the trust. We built up relatively long waiting lists for certain treatments that we put on hold that were considered non-essential, so long-acting reversible contraception and treatments for GU that were, again, not really considered essential at the time. But if we were going to be, you know, adhering to safety guidance around making sure that we limited our footfall significantly, it was challenging to do that without building up these waiting lists. I think there were some challenges with coordinating safety locally with some of the national and local press announcements. So, you know, the thing that pops into my head when I say that now, first of all, is Boris's get everyone back to work push, but yet we need to make sure that we're still, you know, maintaining social distancing and having a lot of the safety measures and have people working from home where they can. We had some challenges with communicating with primary care. I think they were also very overwhelmed, and it was quite sort of difficult to have that communication just because everyone was in the very early phases, at least, quite sort of focused on what we're doing. With regard to redeployment, I think in the early phases, again, there were some challenges around communication with staff. So some members of our service were receiving communication from, you know, a number of different places on a day, and it was quite hard to coordinate where they were supposed to be going and what they were supposed to be doing. But that did improve significantly, I think. And then finally, in terms of what we've learned from the pandemic and what we can hope to take forward in new ways of working, excuse me, with regard to the triage, I think the feeling from the service is that the appointment-only service has worked quite well. It's allowed us to capacity and demand plan quite well, and it's something that was always discussed as the new model, that potentially an appointment-only service would be better, but there was some hesitation about whether we'd still be able to see all the vulnerable patients, but I think it has worked quite well through the pandemic. So we would need to discuss it with our commissioners in more detail, but that's something that I think people would be quite keen to take forward. With regard to the attendances, I think promotion of virtual consultations where possible would be great. It's still something that we need to push as a service, particularly in HIV. I've identified here because we have much stronger relationships with the patients who have been treating them for a long time. And I think it would be good to keep pushing our staff to make sure that they're doing those where possible. Encouraging online booking rather than walk-in attendances, again, is great for capacity planning and helping us know, who we're going to be seeing and why. And it's got that triage algorithm built into the website. And launching and using the self-check-in to limit interaction with the reception staff is really great and can improve confidentiality as long as we have had that. Well, we have had that signed off by the infection control team as well. So it's all COVID compliant. With regard to our vulnerable aspect of the service, consolidating the relationships with the wider health system to support our vulnerable cohort, I think has worked really well and it's been great. And that's something that we definitely want to be maintaining moving forwards. And we want to maintain our audit and safeguarding practices, which we developed during the pandemic when we had a bit of time. I think it's worked really, really well. Our commissioners have been very happy with it. With regard to staffing, I think we're really keen to make sure that we're taking forward some of these flexible measures around working from home where it's appropriate and where it's not needed to, for people to be in the clinic if they don't want to. A focus on health and well-being. So we've got the service manager's been in touch with the newly established wellbeing team, and we're keen to make sure that's a focus moving forward. And continuing to use Teams and virtual meetings, I think is really great, not just for people who are working from home generally, but also, if you're just not able to attend meetings for any reason. Thanks.
Joe, thank you very much indeed. Very interesting. Can you take some questions? Is that all right? Chris?
Yeah.
Well, first of all, as a comment, that was a really excellent presentation. So whoever's coached you in your presentation skills, I think I'd quite like to find out if we could hire them. That was really excellent. My one comment on the content. You made reference to a reluctance amongst our around the cohort of staff in sexual health services to be a little bit anti-video and those sorts of things. Have you got sort of any insight as to whether you think is that reasonable, or are there any sort of, if you like, generic barriers that we're going to face as an organisation as we hopefully move more and more in that direction?
I think one of the challenges on that is around the cohort. So in the health service, a lot of the time, so sort of seeing people for the very first time, you only see them once in a relationship, and you're also discussing sort of things that are relatively personal. So I think that is part of just the service itself. However, we have also had a lot of challenges with a lot of the staff in the service have been there for a long time. They're not necessarily that technologically savvy, and they do struggle to use the technology. And I think we've tried to organise, training sessions and things like that. We've had people externally from the trust doing it. I've organised a training session myself as well on the technology, and there is just a reluctance to do it. That's why we're keen to just champion it in the HIV service, because I think once they've used it a few times and there's actual people in the service using it and saying, this is relatively straightforward, hopefully it can just, take on its own legs from there.
Thank you very much. Mark, did you ever, I've got several people, so just let me, Mark, I think, and then Aileen, David and Naomi.
No, in fact, Martin, mine was exactly the same point, because I was intrigued too in terms of the staff buy-in and where the learning points. So thanks, Chris. Yeah, that was useful, Joe. Thank you.
Shall we do Aileen, David and Naomi then? Aileen. You there, Aileen? I can't hear you. All right, we'll go on. David.
Thank you for that. Like the others, I thought that was really interesting and helpful. And you can see, I mean, as a clinician, I'm very supportive of this sort of work because we do need to reconsider the way that we clinically work with patients. I don't want to get operational, but what I would say is when you make these changes, it's always astonishes me how many rocks there are on the runway. So just simple things like the introduction of patient check-in systems. We had a glut of people who waited an hour because they hadn't done it properly. They thought they had done it, and they didn't think to go and ask the receptionist. So you can't. So my question is a little bit more strategic: is when you make these changes, which are obviously for the good, there are hiccups, there are practical issues, and there is sometimes even collateral damage with waiting lists. So how can you assure me that we monitor this, check, go back and change, and are flexible about the way we follow these things up?
Oh yeah, absolutely, definitely. I think, as you say, that sort of flexibility and willingness to try something new has been very much exemplified by this pandemic and having to make a lot of these changes very quickly. However, we have been responsive. You know, all of these changes around the digital technology model that we've introduced were as a result of patient feedback. So the self-check-in system itself, the waiting times, the fact that people were saying that they had to come in at just times that were designated by the clinic rather than being able to put themselves on. These are all changes that we're implementing as a result of feedback. And I think there's very much just an attitude of we need to have this flexibility to make the patient experience better. And we're willing to, you know, try changes at the very least. If they don't work, so be it. And we can happily move things back. But I mean, I think personally in the service, there's definitely an attitude now that it's time for, you know, any changes that we can to make patient experience better.
Very good, thank you. Naomi.
Oh, okay.
Oh, I think I'm going around the order. Naomi and then Aileen.
Yeah, okay.
Thanks, Aileen. Thank you, Joe. Really impressive presentation. It's kind of an observation really up front, which won't come as any surprise to you. It's interesting that the improvements in service that were planned were planned pre-COVID, and what's happened is that COVID has occurred and acted almost as an accelerant to those changes, and you've recognised that, and I really like that. And you've also kind of modified your change activity set as you've gone, to ensure that the COVID environment has been catered for at the same time. So my question is around kind of timeline now. You know, you've got the accelerant of COVID to get these changes deployed. Has that meant a quickening of the pace of making these changes? And when do you think you'll be kind of complete? So, for example, that you mentioned that the self-service check-in is going to be launched. So that's a work in progress. So give me an idea of timeline to get these changes actually deployed.
I would definitely say that, you know, the pandemic has accelerated a lot of these changes, because a lot of the issues existed previously, but were kind of, we sort of had a bit more of a, I mean, I don't have that much context because I only joined the service in March, but it certainly felt like we had kind of an accelerant to run with it and implement a lot of these things. In terms of timelines, the self-check-in is operational and functional now. It's, you know, it can be used. At the moment, we've just got the reception staff doing it while we wait, like, you know, sort of behind the counter, just to reduce the infection control risks. But that has all been run through with infection control now, and they've signed off for us to use it. The online booking we're introducing again as of the week commencing the 14th, so next week in September, because we needed to increase our number of patients that are visiting the service and kind of reduce that buffering criteria. So yeah, that should all be in place from there. And I think hopefully the full model from, I don't want to put my finger to the wind too much, but very much as quickly as we can.
Yeah.
I think that means Monday next week, Naomi. Aileen.
Hi, yeah, so sorry, my phone had locked, so I couldn't unmute myself. So, Joe, yeah, great presentation. Thank you for that. So my point I was going to make was similar to Naomi's, but I'll ask you, how do you think you're going to be able to work with them?
Aileen, your sound's no good. It's gone.
Apply them in other services.
Aileen, you may have to say it again. You went silent.
Oh, I'm sorry. I guess it was about learning the lessons and then rolling out to other services.
Yeah. So, I mean, I think it's an important issue, isn't it, Joe, that the things that you're learning there are part of a wider strategy of learning how to take the lessons from COVID, the online consultations, and roll it out. I think it's your point, Aileen, isn't it? Yeah.
Yeah, absolutely. Yeah.
Yeah, I mean, we have sort of quite clear, I would say, escalation routes throughout the service. So we work very closely with the head of planned care, and we also have quite monthly project meetings with regard to the sexual health service and all the learnings and things we're discussing there with the divisional director. So she's quite closely, on top of and aware of all the changes that we're implementing, what's working well, what's not. We get the opportunity to present to her. Like I said, it takes about an hour and a half every month. So I suppose it's sort of that we have those very clear routes of information being passed up, to my mind. And I think those probably more senior people then who are in touch with all the other services disseminate those learnings. And likewise, we have meetings with other services. So for example, the planned care in the division every week or two, where other learnings from other services are discussed and passed down to us. So I personally think there's a really good information dissemination sort of system across the trust from what I've seen.
Excellent. Thank you.
Okay, Joe, thank you very much. It was, I echo my colleagues' compliments, an excellent presentation, a very important one. I mean, the trust as a whole is going to be looking at how we get the benefits from the lessons learned from COVID-19, particularly digital remote working, remote consultations. And I suppose my only slight comment is that some of these things are never quite as exciting when they've been downstream a bit. People's enthusiasm wanes, and so it's going to be really important for the trust to understand where the benefits are and are going to stick, and where some of those things that we've done because of the pressures of COVID, actually people will retreat back to some previous way of working, and understanding that dynamic. And the other thing is just about the communities, whether going more remote, for example, which I'm quite a fan of, but are we leaving certain communities behind? Are there people, particular groups of patients who find it much more difficult to engage than others? In which case we had to have a strategy to address that as well. But these are all exciting stuff and a great bit of work that you've been involved with. So thank you very much indeed, Joe. Enjoy the rest of the day. We must press on now.
Bye.
Very good. Okay, colleagues, I thought it was a really interesting presentation. Could we then move on now to the patient experience report? Debbie.
Yes, thank you. So this is the Q1 patient experience report. Activity was generally quite a lot quieter around patient experience in general during April to June. Half of our formal complaints came in for the whole quarter, came in the last 2 weeks in June. And it is getting back now, I would say, to more usual levels of activity. Most of the complaints we received during Q1 were not directly related to COVID. So we didn't have a lot of formal concerns or informal concerns raised in relation to COVID. Most of them were the sorts of concerns and complaints that we would normally receive. And what I did find quite interesting is we had a lot more men as a percentage complaining than normal. So normally about 75% of our complaints come from females, and it was a 50-50 split. And we did have a higher percentage that were partially or fully upheld. So whether it was people that had real legitimate concerns were the ones that were putting pen to paper in this time. We did carry on responding throughout. We didn't suspend all activity, although the national directive was we could put formal complaints on hold. We chose not to do that. We chose to carry on, which I think is absolutely the right thing to do. There's just one update from this paper. So in here I had said that FFT was suspended, which it was, and we had no date for a restart. We do now know that the restart of national collection is the 1st of December, but we did start collecting, as we said we would, on the 1st of September using the new questions. So by the time we have to report nationally in December, we should be well up and running with that. That's all I wanted to say, really, and happy to take any questions.
Any questions, Chris, and then Aileen. Chris, you're on mute.
Yeah, I know. Sorry, I was just unmuting. The one recurrent theme throughout this paper, and actually 2 or 3 other papers, was the word bluebell. It just seemed to, you know, sort of wherever you looked, bluebell was an example of something that wasn't quite going the way that we would want it to. And I just wondered, you know, if there were any sort of systemic reasons behind that, and quite, if you like, if there is a more general issue around bluebell, what the plan is.
So although there were 4 complaints about bluebell, they weren't 4 individuals that were complaining. They've got a new ward manager now, so I would say they have had some change. Am I more concerned about bluebell than any of our other acute wards at the moment? I would say they've got higher vacancy, but they are managing to recruit, and I think they're in a better place actually at the moment, Chris, than they have been for a little while.
Okay,
Aileen?
Yeah, that was exactly my point. The four things that came up from bluebell. You know how come? So Chris asked my point as well.
Debbie, could I just ask one about the ethnicity of complaints? It's actually a wider question than complaints, and it's one I'll come back to. It's about the sort of data recording of protected characteristics of, in this case, complainants, but also, you know, the wider issues of service delivery. Is that going to be addressed in terms of collecting that data on protected characteristics for complainants?
Yeah, so it's something that we gain off Rio if we can, or we obviously ask if not. So you're right, it's a wider issue that we need to address than complaints, Martin. We need to ensure that we have that recorded on our electronic record systems for all of our patients.
Okay, thank you. Aileen, was that another question? No. Okay, Naomi?
Thank you, Deborah. Just a quick one on the shifting mindset. Right at the end of the paper, there's a paragraph on the shifting mindset of complaints, and it makes reference to the change in approach of Healthwatch and the CQC launching a campaign to encourage feedback and not just complaints. And appreciate this is a work in progress, and there's more work to do to roll this out. But do you have any insight, Deborah, on the timeline for that, and any sort of initial thoughts about the impact that might have on our overall complaints, receipts and reporting?
So a lot of this work on shifting the mindset was national work that needed to be taken forward, Naomi. So once they start that national work again, then obviously we'll be able to use those tools, whatever they come up with, is what I would say to that. So we always would encourage all forms of patient experience collation, and I think that's partly why we're doing the new tool, to get more feedback that way, and encouraging all forms, not just written formal complaints. So we will continue on that journey, and then obviously if anything else comes out nationally, we would look at that to engaging in that, any processes that come forward.
Yeah, thanks, Deborah. That's really helpful. My thinking is, and this is future forward. My thinking is we have a certain systematic approach to managing receiving complaints, managing complaints, reporting complaints as things stand. So the current reality. There's this change in the approach of Healthwatch, and there is, in my mind, perhaps a more significant change in the way we reach out to patients to seek their feedback. So I'm just wondering that if in the fullness of time our internal structures in terms of how we process all this stuff might need to change accordingly. But that's just, that's kind of out there, I think, right?
Yeah, I mean, I think, I say our I don't think so. Our new tool will help a lot with this in terms of the gathering of the feedback that's out for tender at the moment. That will be an alternative way of people being able to provide both positive and areas of concern. I think we can use the FFT and the comments that come in through that a little bit better. So there definitely are areas that we can improve. There's no doubt about that.
Okay, Mahmouda. Yeah, Mahmouda. You're on mute, Mahmouda.
Sorry.
That's okay.
I just wanted to ask about the compliments, because I mean, you gave some examples of some beautiful compliments and responses, and because I've been penning a letter to my surgeon and the surgical team and the nursing team on that very basis, Frimley Trust as opposed to Berkshire. But I was just wondering what happens in the sense of, I mean, there was a letter to Julian regarding a colleague on the immunisation team, and then there was another beautiful tribute in relation to a member of staff in relation at Wokingham, I think, end of life. And I just wondered, was there anything specific that the staff received, or, I mean, what happens? Do they just get a well done from the manager, or is it recorded on their performance? It goes into their appraisals, or what exactly happens? We hear about them on an occasional basis. It suddenly occurred to me, I didn't actually know if there's anything formal that goes with it or not.
There's nothing formal. And I know Julian does as well. If we receive a compliment written in to us and we're aware of it, we would always respond back to the person and the service, and we always make sure that the individual actually sees the compliment. They may well take it forward as part of their revalidation. They are registered professionals and they need to collate that feedback as part of their revalidation or use it in their appraisal or whatever.
Right.
Yes.
Okay. So the onus is on them then.
As apart from us acknowledging it to them, absolutely.
Yeah. Okay.
Okay.
Thank you.
It's a bit echoey. Could people go on mute? There's a bit of echo in the system. If you're not, thank you.
All right, Aileen, try again.
So my comment was again about compliments. I was interested to know if we kind of publicise them or make them more public anywhere. But you've really kind of covered that point a little bit. But what are the memory boxes that you referred to in number 14 as well?
They were something that the wards were doing for if patients had died whilst they were on our wards. And obviously during COVID, not as many visitors were able to get in and see people as they normally would. So it was a little box with a little message in it for relatives. I can send you something if you like, Aileen, if you're interested, with a bit more detail.
Very good. Julian, did you want to say something?
Yes, please, Martin. Yeah, I was going to concur with Naomi actually, and obviously this long piece of work with Numwood and KPMG, they're going to provide to some extent some expertise in this area. So beyond the sort of complaints and compliments issue, which we've kind of done in a fairly traditional way, really, through surveying patients, and I think the distillation of information from a variety of sources and how that's pulled together will probably require more analytical ability, although there may be algorithms and things that can help us. So I do think that as part of that stage 2 work and the recommendations from them, there'll probably be some recommendations about how you pull all this stuff together, and that inevitably will start to get us to think about the skill sets of the people who are going to be able to do that, so that as a board you start to receive information in a much more thematic way from a variety of sources, which is obviously not easy to do, and we're probably not so geared up to do it. You tend to get it in silos, and then Debbie and colleagues are then attempting sort of retrospectively, if you like, to kind of make some sense of it, really. So again, I think that will be one of the areas we'll be looking for in terms of the external piece of work, to provide some expertise around how we can get a little bit more sophisticated about that and the skill set. So I'm with you, Naomi. I think that's probably the take us to the next level then.
Very good. Thank you very well, Debbie. Thanks very much. I must say I did like the compliments, the richness of the comments in the compliments as well as the complaints. It helps paint a picture, and they're all interesting. But the one I picked up highlighted was about the mental health patient who didn't have internet or digital access, and we provided something which, to enable him, I think it's a he, to access counselling groups on the internet, which I think was great. And I think it's the sort of thing we need to sort of store away if we're going to move more online, to understand how, again, we people from less advantaged backgrounds aren't excluded. So we need to sort of work on that. But a great report. Debbie, thanks very much indeed. I think we need to move on. Quality Assurance Committee, David, anything you wanted to raise?
I'll give a very, very brief summary. The last quality assurance meeting took place on August the 18th. We started with a helpful presentation and discussion on the Trust Carer strategy, which I think has now moved to an implementation phase. Sexual safety on mental health and learning disability wards is, as we know, an NHS priority, and we were given a helpful update paper. It was assuring to note that CQC were very content with our infection prevention and control measures, which they assessed earlier in the summer. It's mentioned in the exec summary, but we took the opportunity to hear about and debate the Trust staff flu plan. And I think lastly, we just had a general discussion about the committee functioning in view of how COVID may or may not have affected quality. And we particularly asked a question I particularly asked a question for the committee whether they were content, whether 3 months was still appropriate, and wanted to hear their views about the length of papers, because sometimes the papers can be quite long. But actually, we were unanimous in saying we didn't want to change things, and we were pleased with the papers.
Okay. We've got Learning from Death's report and Guardian of Safe Working. Are you speaking to that, David, or shall we just go straight on to the papers?
Well, obviously we do discuss papers, and I wasn't going to say anything. Perhaps I could just very briefly say, learning from deaths always very, very important. The number of potential mishaps is minute compared to the number of patients that are reviewed. And as far as the Guardian of Safe Working, just to give the committee some sort of benchmarking, if you compare the results seen in that paper, which is a matter of a few hours overtime for 1 or 2 doctors. If you compare that with other trusts, which often are different because they're acute trusts, we're in a different ball, is how I would put it. We just don't have an issue there.
Okay, any questions for David?
Just one from me, Martin.
Yeah.
I was particularly interested where it talked about some virtual training on empathetic listening skills. This was something that I was personally involved in probably 10 or 15 years ago that made a huge difference in a clinical setting where professionals had been conducting themselves in a very clinically correct manner or professional manner, but are not connecting with patients or with customers. And I was just interested in learning more outside of the meeting in terms of the work that's being done there, because I'm a great believer that can make a huge difference where the clinician is able to gain empathy and rapport with the patient as opposed to just simply a straightforward communication. It was on page 2 of the report.
I don't think I can respond to that other than to say, as from a clinician, when I trained, I spent a huge amount of my training was about how you obtained information and obtained the trust and confidence of patients, and how you use that time for the best endeavours. and we've moved into a very technical world. So much of what young doctors do is very different. So I think it is a good opportunity to reconsider that. Yeah.
Okay. Thank you very much, David. Can we move on to executive report? Two big things here. One is vaccinations, and the other is the pulse check survey. Very positive. Just on the vaccinations thing, Debbie, you've made a comment that the things you're doing. Why do we think it's going to be much better this year than last year? And because we did okay, but we weren't quite where we wanted to be last year, if I recall. And this year we got more pressure to get more people vaccinated. Do you have any strategies about how we get there, or is it more of the same? Sorry, that sounds a bit negative. I don't mean that to be negative, but I mean I know it's very.
No. So yeah, we got to 70% last year. And I would say we get 65% historically quite easily, and then we have the rest of the people that we need to persuade. There's definitely more talk amongst staff this year about them having it, because I think having had COVID where there isn't a vaccination that may help brings into stark reality for people where there's flu that there is something. And if I'm really honest, there will be a couple of people we need to do some persuading.
Okay. By the way, I'm having mine done on tomorrow, so you can tick one off anyway. That's
very good. I didn't know the vaccine had arrived yet, Martin.
Well, our local pharmacist is going to inject me with something tomorrow. So
excellent. We're expecting our vaccine to be with us next week, so our campaign should be starting next week.
Very good, thank you. And could I just ask Julian just to say a little bit about the pulse check survey, because that's very positive results.
Yeah. Yeah, delighted with the outcome. I think a couple of things in play. Obviously, a bounce from the CQC outstanding. I think there's definitely something around that. Obviously, this was completed just a few months afterwards, and there's no doubt about it that obviously the new style of communication, the fortnightly broadcasts, initially weekly broadcasts, have made an impact in making people feel connected and obviously improving the sense of communication. So I think it puts us in a very strong position. Just be clear, these are not good. They are class-leading results, not just by NHS standards, but these are standard questions asked in any industry around staff engagement, and they're at the top of the, pretty much anything an organisation would see, including 80% of people saying they strongly agree that we manage COVID well. Well, you won't find many organisations with that level of endorsement. So they are a fantastic building block on which to think about our strategy going forward. I'm not sure we'll necessarily be able to maintain some of all these scores. As I say, I think there was a particular moment in time. So I think historically we just need to be mindful of that. But there's certainly some areas where we could look to push on. With communication, we are nevertheless aware that particularly inpatient colleagues are less connected still. They don't have an opportunity to sit down and watch the broadcast. They don't have access to PCs and laptops to be able to catch up afterwards. And that's been an issue we've wrestled with for a while. So it is a focus for us as an exec team and leadership team, thinking about how we can get that cascade into our inpatient areas to make sure they feel better connected. A number of colleagues who don't normally work in inpatient wards, actually work in community, they might be managers, were able to reflect on that experience, about how different it was for them and how difficult it is to get information when you're rushed off your feet on a busy ward and there's only 3 or 4 computers available. So there's always things to do, and of course, as we know later on in the reports, that not all staff feel equally as positive. So there's no complacency here, but I think the team, my colleagues and the senior leadership team, should be congratulated for leading the organisation so well and resulting in such a very positive survey. I was delighted, I have to say.
Julian, I'm sure we all would want to record our thanks to you and your colleagues. It is a fantastic result. So thank you very much for your hard work. Any other questions from colleagues on the report? No? Very good indeed. Thanks so much. Could we then move on to performance, the finance report, Alex?
Thanks, Martin. So finance report in the July month 4. We're still in the COVID transitional financial regime. So we're being funded to break even effectively, inclusive of our COVID related costs. That regime, that break even funding regime, will extend to September, so to the end of period 6. And beyond that, we're waiting to receive system allocations for COVID funding. So we won't get retrospective recovery of COVID. We will have to allocate from a centrally determined pot for COVID. And we're also waiting to hear what our block allocations will be for running our services. So there's a little bit of uncertainty about the second half of the year. In the context of that uncertainty, we've been asked to submit system forecasts for the rest of the financial year, which we've done, making some assumptions in the absence of those key numbers in terms of allocations. So year to date, steady really in terms of our underlying position. So a small surplus before we take into account COVID costs, and I expect that to continue with some upturn as services begin to step back up. And we see the marginal costs of activity coming through and staffing coming through as services open up. Those costs have been accounted in our forecasts, and I'll update the Finance Investment Performance Committee when we next meet about what that is looking like. Very happy to take any questions.
Questions for Alex? Chris?
Just make sure I'm not muted.
No, you're all right.
Oh, very good. Alex, normal balance sheet question for me, and I presume the answer is the same as usual. Is the grossing up of debtors and creditors just because NHS Property Services are playing silly beggars? And secondly, you allude to second half risk as a result of not really knowing what the financial regime is. Could you just sort of say just a touch more about that? Is that something that's keeping you awake nights, or is the general feeling that that we might get some kind of soft landing out of that?
Okay, so on the receivables and payables, yeah, there is the interplay of NHS Property Services, but this is short-term movements. We don't have any risk. Actually, we've got better sign up around POs than we have before with NHS Property Services. So that's all fine. There's no risk building there. And in terms of the forward position, our underlying cost base is better than we had expected pre-COVID for various reasons to do with remote working and reduced travel, training, all those kinds of expenses. They are playing through into our forecast. I think the uncertainty is what our 2 ICSs will be allocated for COVID-related costs. We are forecasting 3.2 million in the second half of the year of COVID. Now, if they're using a run rate for the NHS and they give that a haircut, then there's going to be some challenge in the system about where those COVID-related funds go. And I expect there's going to need to be some prioritisation against current forecasts as we move forward, and that's where the risk will appear. But in terms of our position, we've currently forecast a 3.5 million deficit. That is an improvement on the early views, but as I say, it's based on a set of assumptions around our funding that are not yet clear. Systems are expected to achieve a break even at aggregate level. There can be offsets between systems, so I give you that 3.5 million number as a kind of realistic view on some assumptions at the moment, set in the context of quite a challenging forecast view pre-SIP that we had back in March. So underlying, I think there's an improved position. We're working through what the funding is going to look like for the system. So that's the uncertainty, and then how you allocate and prioritise within the 2 ICSs.
But there's no sign of them wanting to roll back on the things that we've done that sort of facilitate early discharge and, keeping people out of hospitals, those sorts of things. There's no loss of enthusiasm for those processes.
They're absolute priorities for the system to support phase 3 and recovery. And Berkshire West is working through with local authority colleagues a substantive model for rapid community discharge, of which we're going to play a key part.
Thanks so much. Aileen.
Yeah, mine's a quick question. You said about the underlying cost base being lower than or lower than we anticipated, but one of the issues we were having were people using their mobile phones and using their data. Has that been resolved? I saw it somewhere in the papers, but I can't recall what was said.
Yeah, it has been resolved. So we got a bit of a scare on our retrospective billing from EE under the new contract 4G data charges for people remote working, where they've either not got broadband or they hadn't switched over to their own home broadband. Those are the main drivers for the costs. We've renegotiated the position with EE and our forward contract to have an increased data cap. So we had a data cap of 2.5 terabytes. We've now moved that up to 7.5 terabytes. And with a new application called Wandera, we're able to support colleagues to move off 4G onto Wi-Fi or understand specific issues which may need other solutions around broadband or ways of working. So confident we've got that under control with our new contract and the software.
Thank you so very much. Naomi.
Yeah, Alex, this is probably an anticipatable question from me, but do you have any insights on this kind of mood music at LHSE level around the costs reductions that we've seen because of changing working circumstances and COVID, and any expectation at the centre that those would become kind of permanent, and not just within our trust and elsewhere, because obviously there's a tension there between that and the possibility of a second wave and also trying to get services back up. So any thoughts?
Yeah, our understanding is there's likely to be an efficiency assumption that comes down into system allocations on our blocks for the next half of the year, which intends to make sure we've still got an eye on productivity and are baking in those changes into service models. I think the challenge around phase 3 recovery, and particularly for acute partners, is this is going to cost some money to get back to 80-90% of standard activity when you've got the impacts of COVID and use of estate and infection control. But I think we need eyes on our potential cost-based changes that have improved, because I expect there'll be an expectation on it.
Okay, Alex, just a question from me about capital expenditure. Section 4. I was just slightly surprised, and maybe it's just a timing issue, that the capital expenditure on IM&T system and networks is well behind plan. Is that just a timing issue, or is there some rethinking what we need to spend our money on?
That's going to be a timing issue. So that's where we have our standard replacement kit going through. We're confident around the year-end position on capital.
Okay. Very good. Anything else on finance? Performance?
So performance, we've noted the exceptions in the cover. Happy to take questions, but generally there aren't any particular exceptions to highlight to the board, and we can still see some good movement and holding of performance around some of the key trends on our drivers.
Yeah, any questions? Steady as she goes. Good.
I think Chris has got one, Martin.
Oh, Chris, you're on mute.
This technology, it's doing my head in. I'm just sort of struggling to, I won't say to find it, but just to make sure I've got on the right place. Yeah. At the risk of revealing myself to be a complete idiot, can you explain on my packets, chart 121 of 186, the patient experience clustering breakdown? I just, can't quite get my head around what it's trying to tell me.
Sorry, I haven't got page numbers on my pack.
So it's patient experience clustering breakdown, it says. Well, there's a line drawn at 80% across the chart, and then there's a whole load of red below it and a whole load of green above it. And I just wonder, it's obviously trying to send me a message, and I just couldn't quite for the life of me work out what that message was.
So the diagram shows you we've got a target of 80% for patients to be allocated a cluster group, and the greens are people who are 80 and above, and the reds are the teams or the areas that haven't.
Yeah, without being facetious, I got that. But it was, was there something common point of entry and psychological medicine service being, quite so far below 80? Was that something that should be ringing a sort of a concern bell, or is it just kind of the way it is?
It's complexity. So no, I mean, ideally you'd like to get there, but it's easy to cluster somebody in a service where you know they've got an eating disorder perhaps than it is for somebody who's on first presentation to common point of entry or turns up at A&E, and to have a definitive idea about their clustering tends to be more complicated, Chris. So there is a level of complexity, isn't there?
Okay, yeah, no, I accept that. I just wonder if there's an easy way of sort of showing, because something might be red, but it might be, should we say, as good as it's ever going to be, and something might be green on here, and it might be there's an opportunity to make it greener, you know. So, I just wasn't getting that, and moreover, I wasn't really even sure if that was even an important question, given you know the overall complexity of everything you're doing. So, I looked at it, and it was just they were just different coloured lines to me. I didn't get the message from it.
The background to it, Chris, is that the target originally was 95%. It was a tracker metric and we weren't achieving it. So we wouldn't normally have seen this level of detail in this report because it's a tracker metric. But because we weren't achieving the target, we decided to request a review of it, and we wanted the breakdown. And what we've seen is a gradual increase, but we've now altered the metric to 80%. So as we achieve 80% overall, this breakdown will disappear, but obviously those services that still aren't at 80 will continue to work on it. But that's why it's in here. It was to give us that visibility as we were reviewing not achieving this metric.
Gotcha. So maybe to sort of make it clearer, maybe an arrow on it that just shows the direction that these lines are taking over time, so that we can see that the items that were, say, caused us to be below the 95 and caused us to shift it from one to the other, you know, are they moving in the right direction, or something like that might just make it that I don't sort of sit staring at it thinking, what should I do with this?
Yeah, as I said, it won't be there, because once we hit the 80%, then we won't need to see that level of detail for this particular metric. So
I thought the target was 95, and
no,
we'd
we
only
reduced
started
it to 80. We reduced it from 95 to 80.
Oh, right, okay.
All right.
Yep.
That's great. Any other questions? Can we move on to 8.2 then, Naomi? Just anything you wanted to report on FIP 30th of July?
Yeah, thank you, Martin. Just recognising that there were two items that were actions on our action list that were closed out at the last FIP, which was on 30th of July. At that meeting, we were looking at the June financial performance, and I'm happy to take questions on that. But the two items that got closed were, you'll recall back in the early part of this year, we noticed as a board that there'd been a observable increase in the number of resources or FTEs in the management and administration category. And FIP were charged with going away to take a look at this. And I just wanted to highlight briefly the outcomes of that conversation. And Alex, please jump in here if I miss anything. Since April 2018, which is a sort of starting point for the increase in this headcount number, the number of FTEs has gone up by 113, which of course is material. But it can be explained by a number of things. First and foremost, a kind of underlying increase across all services. So all services have increased their admin headcount by, the sort of between 3 and 5 people. So, literally less than a handful of people have increased their administration staff. Then there's a reclassification of administration staff as we moved folks out of being capitalised under GDE and into revenue. And then I think, in my mind, more importantly, there's been a growth in a number of services, or an expansion of services, which has warranted an increase in the number of administration staff. So, for example, talking therapies, physio, and NSK. So, a kind of cornucopia of reasons why this number has occurred. I would stress from the get-go that this was planned. So back in 2018, there was an absolute recognition that we were under-resourced across the requirements for administration amongst all services. So a plan was put in place to address that. My observation would be that back in 2018, we were under-resourced, an acknowledgement that the requirements of the NHS from an administration perspective weren't going to decline. So we needed to ensure that the clinical staff in particular were dedicating their time and efforts in the way we would expect and being thoroughly supported by administration staff. I think beyond that, the message the committee wanted to send were sort of twofold. One is that we've now really achieved, I think, the resourcing levels that were planned, and our expectation going forward, we would not see any material increase unless there was a significant change in the overall demands of the services. We also recognise the current context, which is complex because of the COVID environment. So very resistant, as you would expect, to asking for a material change at this moment in time, given where we are. But also recognising that longer term, there may be an opportunity to look for simplicity, look for reduction in administrative staff as simplicity emerges. And I sort of caution that, I say that with caution, because will simplicity emerge? But the hypothetical there would be with increased use of technology, consolidation of people working from home, etc. That might be something we could hope for. So that was one item that we felt was closed, and we're happy to kind of move on from it, keep it under observation, but the analytics and the data that was reported and recorded to the committee, I think was satisfying. The second was we took a look at disciplines and grievances. You might recall that for the first time we wanted to take a look at discipline and grievances across the trust, looking at it historically, so the numbers of disciplines and the timelines for closure of these over a period of time. And a couple of things popped up. One was that over the last year or so, there has been an increase in the number of cases, and also the way in which these grievances and disciplinary caseloads are dealt with. There is a noticeable difficulty with resourcing the officer and team that are required in order to deal with them and get closure. So the thinking going forward is that directionally the team are going to look at a dedicated officer to deal with grievances and disciplinary cases, with the possibility of this being a system-wide initiative. There is further work to understand as well the levels of disciplinary cases which involve our BAME community, which is very much at the heart of all our thinking at this time, and always, in fact. So the committee were very encouraging to see that piece of work go forward and see whether or not we can recruit a dedicated officer to up resources in this very important area, and indeed see this report as being a more standard report for the board going forward.
Naomi, thank you. Any comments for Naomi? Questions? No, thanks for reporting on those two. They're both important issues, and I share your views about the future in terms of staffing, because we need to find the most efficient way we can to deliver the best care we can for the money available. So, and hopefully we'll find some new ways of working that we can enable us to do that more efficiently, but who knows until we've actually tried. And on the disciplinary one, you talked about system solutions. I wasn't sure what you meant by system solutions.
So go ahead.
Sorry, just it's around getting a pool of experienced resource that the system can share, that takes the burden off operational managers or service managers doing the investigations. That'd be a cost-effective and efficient way of delivering investigation officer resource.
Okay. Thank you for that, Alex. May I move on? Now we're on to two quite important papers. Item 9, Workforce Disability Equality Standard, and then the Race Equality Standard Report. Catherine.
Thank you. Firstly, I think I probably want to say a huge acknowledgement to the work that both Sandra and Joe have put into both of these reports. They're not here, but we need to acknowledge the fantastic work that they've done, and actually at quite some pace, because you'll remember that actually these original reports have been suspended, so they've completed these at quite a pace. The key messages from the WDES paper, that in terms of where we sit, in terms of our benchmark group, we're actually above the benchmark in terms of numbers of disabled and non-disabled staff in the various bands across the organisation, so that's really good. There are a number of key areas that we know we need to focus on, and they're written into the narrative of the paper. Work-related stress is one. Improving the experience of staff and staff working within their teams is another. There is an issue still about the rate of declaration, although that has improved somewhat, and we do need to, and we have released this, the implementation of the 2020 reasonable adjustments policy. Now the paper asks you to approve the paper which has been submitted. The timescales didn't work brilliantly, and an action plan. We haven't attached the detailed action plan yet. The actions are written throughout the narrative in the paper, and we do need to draft a detailed action plan which will have milestones and timescales, which will, if you approve, go to the diversity steering group for both approval and oversight of progress. They're the key messages. I'm going to stop and see if anybody has any comments or any questions.
Any questions, comment, Deborah?
Sorry, getting off mute. Catherine, it might just be me, but I was getting a bit confused with point 6 in the WDES report, and it was talking about 0.02 and then it started talking about 9.61, and I was just a bit confused, and I thought if it was going for publication, then others might be confused if I am.
I was.
Yeah, that's helpful. I think what we'll do is clarify that we're looking at two different data sources. One is our reporting in ESR and the other is from the National Staff Survey. So I'll look at that and I'll make it much clearer, and that comparison happens in a couple of places in the paper, so I'll make sure it's clear throughout.
Okay, Mark.
Catherine, I appreciate the action plan hasn't been produced, and that's the next stage. But for me, the areas that you needed to focus on were the harassment and bullying, and also the stress. And I didn't get the sense in looking at a lot of the actions coming through from the narrative that those were highlighted. They felt to be more generic. And I'm just feeling that in that action plan, they need to be much more accentuated and brought to the fore, because otherwise I feel the two key issues that need to be addressed are almost secondary to a number of the others, more generic areas.
Thank you, that's really helpful observation. I think what we've probably not made the mistake, but I think when we look at the WRES report, and we've really highlighted the bullying and harassment much more strongly in that, and I think probably we need to do the same in both. And I think we've been working on the assumption that if we get it right for one group of staff, we actually get it right for all staff. But I think I take your point, you're absolutely right, it needs to be much more explicit.
Thank you.
Any other comments or questions for Catherine? Catherine, you've talked about, in terms of the paper, you've had some comments from Debbie and from Mark, which I assume you'll take account of in some minor redrafting. Is that correct?
Yes, absolutely.
Okay. So on the basis of that, are we happy for this to go forward to publication? Okay, thank you very much for that.
Sorry, can I?
Oh, sorry.
Sorry, Martin. Martin, how are we doing? Obviously, we always want to be the best and improve and everything else, but just generally, how are we doing? What does this tell us overall? What should I take? Are we better than most overall, or?
We are slightly better in terms of our benchmark group. We are improving, and we only had established the Purple Network in 2018, so actually it's still relatively new. But what we're highlighting is, although we're better than our benchmark group and although we're improving, there are still areas that we need to focus our attention on, and that's what we will pull out in the action plan.
Is the benchmark group a very small group, though? You know, are we sort of comparing ourselves with just a small number of trusts as opposed to 290 odd trusts, NHS trusts? Is it just the community mental health Trust.
Yeah, the benchmark group is quite small, but that's, I think, why we've included the data from the National Staff Survey. That gives you a much broader comparison. But I accept the point that we need to be really clear which data source we're talking about when we're doing that comparison, because otherwise it can get slightly confusing.
Thank you.
Just to follow up on Julian's question, Catherine, when will we be in a position, because this is relatively new compared to the race equality standard, when will we be in a position, I assume nationally, I think I'm talking about, to have good data that helps us understand exactly where we are and compare ourselves? Is that going to be next cycle, next annual cycle?
I'd probably recommend 2 years' time. You usually want to have at least 5 years to be able to look at trends. And then, but of course, 2020 might have some very different results because of the impact of remote working and COVID. So we might need to take that into account when we look at the results next year.
Okay, thanks for that. So with the additions to take account of Debbie and Mark's comments, we'll approve this for publication.
Sorry, Martin.
Yeah, Mahmood.
Yeah, can I just ask a question about something,
please,
if I may?
Please.
Yeah, so it was in relation to the comment that disabled staff are more likely to feel pressured to come into work. And I just wondered, was that pressure coming from, did they feel themselves that they felt that, or was that because of experiences that they had from managers and colleagues? Because I wasn't quite clear.
So the way the question is designed, it will be a self-reported pressure, but what you'd actually need to do is talk to those staff to find out whether that pressure is an internally imposed pressure or whether it's because my manager is. And I know the Purple Network are intending to do some more detailed work and to get underneath all of these issues.
Okay.
Is that all right? Okay. Could we then move on to the race equality standard, please, Catherine?
Yes, thank you very much. And again, a thank you to Joe and Sandra for this. The key messages, again, the results for BHT, we are above the national average in most of the key indicators, and there is a gradual progress is being made closing the gap between the white and BME staff lived experiences. BME representation across most of the Agenda for Change bands has improved, but there is still some work to do. And in particular, we have seen the reporting of bullying and harassment still remains to be an issue that we need to focus on. We are aware that BME staff are still more likely to be referred to the formal disciplinary process, and I was really interested in the ideas that Naomi had in terms of how we might take that forward. More BME staff are still reporting that they experience discrimination at work from their managers and colleagues. We did have the Making It Right programme that did run, and it was seen to make a positive impact. We did pause it to do an evaluation of it. It was a pilot. We are committed to continuing that going forward, and that work, the design work is very current. But we do now need to think about how do we deliver this in the context of COVID. So we are very aware of that, and we're currently working that through. So again, the key message is that we have made some improvements, but there are still key areas, bullying, harassment, the disciplinaries and experience being the key areas that we need to focus on. Again, we need to design a detailed action plan with outcomes and key milestones and resources, and that will go to, if you agree, the diversity steering group for sign off and for the watching brief in terms of implementation. Happy to take any questions or comments.
Questions for Catherine, please. Chris.
Just an observation on Appendix 2, Catherine. It's very clear. The progress is very clear to see that certainly on the, should say, on the clinical side, we've made great progress, and perhaps less so on the non-clinical side. Is there a sort of rationale behind that, or do we need to perhaps have some you know, it may just be that it's the law of smaller numbers that's at play when you get down to sort of bands 8B, 8A to 9 and stuff. But are there any sort of specific things that we need to perhaps consider in non-clinical areas?
So I'd need to take that away and come back with an answer. But you are correct in that the improvements we've made do tend to be in the lower bands. There may be part of the answer, maybe because we're looking at smaller numbers. But rather than just assume that, I think I'd rather go away and do a little bit of analysis.
David and then Julian. Oh, and Naomi.
Yeah, on that one, Chris, when we first started out on this, we had deficits across the whole range of bandings. But what we knew we needed to do as the first thing is to get people into 7s and 8As, because you wouldn't be able to get people from the junior level straight in. And we wanted to develop internally rather than bring people from the outside or have some big program of bringing in a positive discrimination. So we've been successful in that first phase of getting that up. And now the next phase would be to get them into higher bands and to address that as well.
Yeah, I know, I'm completely with that, and that was always my thought, was that was the most sustainable way of doing it. I just wondered if there might need to be a sort of a little tweak of the tiller in the sort of non-clinical area to take that successful strategy and make it successful even in some of the other areas. But I completely buy your answer, and it's the right answer. I think that, you know, doing it the way we've done it has been the right way to do it.
Yeah, and you're right, it is very small numbers, so it's 1 or 2 people in some of these higher bands that's what makes a difference, and we don't get the turnover at the same rate as we would with the other bands.
Julian?
Thank you. Yeah, it's a point I make every year, and it goes to Chris's, which is there is a methodological issue as well, Chris, because in those 8D bands, because there's 2 doctors who are clinical directors, Raja Nataraja and Nab Sodhi, they're excluded. So there are 2 BME members of staff who we exclude from our clinical directors because they're not on Agenda for Change, which seems extraordinary. So if you actually look at the everybody who's at 8D or 9 equivalent, you'd see many more BME staff in that category. So again, for me, you know, it kind of misses the point slightly there, because I think actually we're quite strong at those high levels. And again, it must be an issue nationally, but it is a bit frustrating, really. So I would actually say if you included those 8, it's probably the 8 Bs and Cs that are probably okay.
Okay. Now, did I miss someone? No. Okay. I've just got a question for May on.
Martin.
Oh, sorry. Oh, Naomi, sorry.
Very quickly, and it's almost certainly a point I've made historically, so forgive me if I sound a bit like a broken record, but I on our diversity and inclusion agenda, so I'm talking now quite broadly around race, disability and sexual orientation. I do sometimes wonder if we're tapping into external expertise in a way that we could or should. I know that there is so much knowledge and insight into these matters within the NHS, so I'm not decrying that. I just know that when we as a trust go external and look beyond our own boundaries, it usually works. So maybe just a takeaway to think about.
Yeah,
I think that's a good point, Naomi. On the sexual orientation, we work with Stonewall, who are externally who are predominantly blue chip companies. So in that league table we're up against, it's Amex, Lloyds of London, all those kind of. So we're learning from them on that. I think you're right around disability, and I would say race. There's not many blue chip companies who've got that one right as well. They've definitely got the sexual orientation, gender, but race generally is actually quite poor. In so, you know, you look at FTSE 100 companies, stuff like that, they're not very good in terms of that element of it. And the NHS probably has looked and has not found many beacons there. But I think with disability and I think with sexuality, there is definitely organisations externally that have pressed ahead further and faster than us.
Okay, thanks so much for that. I just there's some data, Catherine. Are you there? Oh, yeah, Catherine, and about the relative likelihood of BME member staff being disciplined, which you mentioned, you talk about, but they're quite high figures there, and I don't know whether they would change and the probability of being promoted, you know, over a white member of staff. We're only at the national average on the figures are presented here, or worse. Do you think they'll improve when it gets to 2020? Because I assume they haven't taken account of the latest actual results. Is that true? I'm looking at, you know, the table 2 clinical workforce and the little bit beneath it at the end of the paper.
Yeah, we did introduce an anti-bullying and harassment campaign, and we have seen a significant reduction in reporting of that. So yes, I would hope that that continues going forward. But clearly, we've still got work to do on that. So we just need to maintain a focus. I am a little bit worried about the context that COVID might present to this and what that might mean and how people feel. So I do think we might need to look at that in that context when we look at the results for next year.
Okay. And my only other comment, thank you very much for your colleagues for the paper, very clear, is I think we just need to make sure that we are checking against all the protected characteristics. Well, clearly there are some which are more important at the moment to address, but I think we need to have a standard process that just makes sure we're checking against all the protected characteristics. Otherwise, you might find something we're overlooking and then it pops up, and we need some early warning if there are issues there.
Yeah, that's helpful. Thank you.
Thank you very much indeed. So you want us to approve this too, Catherine?
Yes, please.
Approve publication of the results and action plan. Everyone content? Okay, take that as content. Thanks so much indeed. Catherine, one more for you. COVID-19 recovery plan report. I think it'd be helpful, if you don't mind, if you're able just to paint a little picture of where we are in the recovery. That's it's quite a detailed report, and I think it'd be useful just sort of paint that top level picture.
Yeah, in terms of the top level picture, all of the community services are now operational. The vast majority are operating, sorry, what we call a blended model, which has both accelerated a number of the ambitions that we had, but also has its challenges in terms of some of the estates, because of things like social distancing and the cleaning we need to do between each patient being seen. So at a high level, we are the community services are all back on. They are operating quite differently, a number of them. There are capacity issues, and we have now what we call a heat map, which is very helpful in setting out where the challenges are. We need to work those through with the services and communication with patients. And we're now currently working through our mental health services in terms of recovery and restoration. We've submitted all of the required plans to both systems as part of their planning for recovery and phase 3. So that's all completed. And we're currently updating the risk log and action log to go forward. I think that probably gives you a highlight of where we are.
Thank you very much indeed, very clear. Comments and questions for Catherine? Chris?
Yeah, I'm on. I had just a couple of questions. One was on page 165, the EUPD. If you recall, about 18 months ago, when we were having the conversation about, the bricks and mortar that we needed for our future services, the one project that was seen to be the driver of our future ability to generate additional capacity, EUPD was very high up on that. So I just wondered, where we are with all of that. Really, is everything still okay?
Then I think I'll respond to the EUPD question, which Chris has posed. And in reality, Chris, you've had some minor setbacks with the project, so to say. So COVID sort of slowed things down, as it did for every other clinical service. We lost tragically one of our really good clinical leaders who was sort of taking forward several aspects of the program, and we have our project manager who is leaving end of September. So a lot of the continuity has been partially disrupted. We are also developing the inpatient end of the pathway to link it up with the rest of it. So in a sense, maybe the pathway from green may be having a tinge of amber now, but there's no reason, I'm assured by colleagues who are running the show, and also as far as I'm aware, that we won't be able to deliver the sort of end product sometime early next year.
Okay.
I mean, that's great. I just wonder, do we have a risk that we need to think about in terms of our ability to manage the amount of inpatient capacity if we're not going to be delivering the benefits of EUPD in a way that frees up that capacity? And that could be I suppose that's a short-term capacity risk and also a very short-term financial risk, because we'll be into more out of area placements and all of those sorts of things.
Yeah, so that's right. The whole, one of the reasons for the besides improving the quality of care for all patients in community services, etc., was to manage the inpatient flow. So, in response to your question, things really can't get worse. If anything, there are elements of the pathway delivered, more staff are trained up, things are better. In your answer to when we will see the impact on inpatients, I think we'll have to wait for the whole pathway to be up and running next year and then evaluate after that. So it's a fair question. Some of these things you can only determine after the whole pathway is in place, Chris.
Okay, thank you very much, Minnie. Thank you, Chris. Could we move on then to, Catherine, your last strategy implementation plan report, which I read as being stuff getting back on track. Is that my one-line summary?
Yeah, it basically gives you a little bit of a summary. I mean, people will appreciate that various different strategic initiatives have had to be paused, but we are bringing them back online in an ordered way to make sure that we don't suddenly go from from standstill to trying to do everything as well as trying to do COVID and recovery. So I'll take the report as read, but happy to answer any questions people may have.
Any questions for Catherine? No, none at all, Catherine. You've sated their appetite. Could we then move on to audit committee meeting? Chris, anything you want to raise?
Yeah, well, just to say, you can see it restarted. Clearly, as usual, take it as read and understood unless you come back. We had an excellent, our deep dive was into the area of the apprentice levy, as you would have seen, and that's not just because it's a big chunk of money, but it's also a big chunk of opportunity. So it wasn't wholly financially driven. I would have to say that every time I have an encounter with Jane, I get more and more impressed. She's clearly very driven and very competent and capable, and I really enjoyed. I've had a follow-up meeting with her and her team after that presentation, just to see what what I can do to assist. The one thing that the board needs to sort of, should say, have its head around is this is a use it or lose it pot of money. And we are getting to the point where in December we start losing it, not in big numbers, but we do start losing it in quite big numbers into the spring of next year. So the impetus has to be to get some of the schemes that Jane and her team are thinking about, getting them working. Otherwise, we would have, if you like, spent the money and not got the benefit. So that's that's that. The audit committee, even with people dialing in from many different organisations, internal audit, external audit, counter fraud and the like, worked very well on Teams, and frankly we could continue on that basis without detriment, other than the loss of the, if you like, the between financial FP&A and audit. We've been having those sort of development lunches, and where we've been taking subjects apart. Clearly we're not going to be able to bring those back online until such time as we're meeting in reality rather than virtually. But other than that, I don't know if Naomi and Mahmuda, you were there. I would say it was as good a meeting as A, we needed, and B, we've had in the past.
I agree. Thank you, Chris.
Okay, very good. Let's move on. Councillor Governor's update. I don't think I've got anything new, unless Julie can prompt me, anything new, apart from the fact that Paul Myers-Coe has been re-elected as the chair and Susanna the vice chair. So I think that's the latest hot off the press news. And of course, we have the AGM coming up, which will be interesting to see how that works, but hopefully positive. Schedule of meetings. I think that's just for information. Any other business? Okay. The next Public Trust Board is the 10th of November 2020. We'll now consider our resolution to exclude press and public the remainder of the meeting to be prejudicial for public interest. So thank you very much, everyone. Thank you to the colleagues who've come and presented. Interesting meeting. And I think what we'll do is now, shall we start again at 12? Would that be all right? Time for a coffee and a break. 12 o'clock then for the in-committee session.